Okay, this video is going to be how to do a spinal tap. Spinal tap's also called the lumbar puncture. I've done probably, I don't know, about 600 of them. Here is a book that I wrote years ago, I think around 2003, called The Pocket Radiologist. It's a guide of imaging guided surgery. Interventional radiology is the same thing as imaging guided surgery. So here's my name right here, Rogers. I was the main author. These are contributing authors. Okay, it was published by Amasis Elsevier, which is the best publishing company in radiology and medicine. It was a pretty popular book. It got translated into Spanish, Radiología Intervencionista. Let me show you now how to do a lumbar puncture. Okay, I get a lot of people asking me how to do lumbar puncture. So here it is. Now, first of all, here's just a simplified drawing. I usually do lumbar punctures with fluoroscopic guidance. I've done a bunch of them with no guidance at all, but usually I use fluoroscopy, x-ray guidance. So here would be with the patient on their side. It's called decubitus positioning. Here's the needle going through the intraspinous ligament going into the epidural space, into the cerebral spinal fluid of the lumbar spinal canal. Here would be with the patient sitting. Okay. All right, now here's showing you one way to check your depth. You can feel the top of the iliac crests, and we sometimes call it the pelvic brim. And then you can just see, that's going to put you in the lower lumbar spine around L4-5, L3-4. That's a reasonable spot to puncture when you're going by palpation landmarks. Okay, now here's a really key slide. If you're like a young doctor who's going to be doing this, this will be like probably the most important thing you learn here. You have to learn how to control the needle. Needle control is a key skill if you're going to become good at doing stuff. This is the hub hatch, the ridge on the hub. This is a 22 gauge needle. Usually you're going to be using a 22 gauge needle or a 20 gauge needle. Typical needle length 3.5 inches. The longer needles are about 5.5 inches. You're typically going to have what's called a quinky tip, which is a beveled tip. Okay, but here's the key point. With the hub hatch, I call it the hub hatch, it's going to be on the same side as the bevel, on the same side as this. And when you advance this needle, it's going to be directed away from that. So it's going to go this way, away from the hub hatch, away from the bevel ridge. It's going to go down. So I always start with the hub hatch facing me so I know where it is. And I know the needle's going to go away from there. Because you're constantly going to be fighting a game of millimeters. You're going to have to get into a tight space. I'll show you what that looks like in a moment. And you're constantly trying to buy a millimeter or two. So you try to line up the needle so it's straight hub over tip in the direct path of the x-ray beam, and you want to center the x-ray beam. Let me show you what that looks like, but you have to know this. The hub hatch is on the same side as the bevel, and it always goes away from the hub hatch. Always goes away from the hub hatch. And by knowing that, you can constantly readjust your position. Because again, you're going to be fighting a game of millimeters to get past the bone, the lamina, to get into the intrathecal space. Okay, that's what the whole game is all about. So here be how I line up a typical lumbar puncture, okay? You start with the patient for lumbar punctures under fluoroscopy prone. Okay, now this is an idealized patient from a journal article. In real life, they don't look like this, okay? Look at these big honking interlaminar spaces. So the bone projecting towards us right here in the middle, that's the spinous process, okay? And this right here, this bone right here is the lamina. So this is the upper lamina, the lower lamina. In between the two lamina, that's the interlaminar space. In between the spinous processes, that would be the interspinous space. So if you're going right down the middle, like at a bedside puncture where you don't have any fluoroscopy, you might go through this ligament, which is a pain in the butt because the needle will often bump into the bone and you got to keep on adjusting it. And it's a bit of a pain in the butt, and you have to sort of extrapolate, guess the angle of the spinous processes. By the way, I always check. I'm going to show you more detailed instructions at the end, but I wanted to show you the pictures first so you'll be able to picture it in your mind's eye as I talk about it. So what I typically do is I start with the patient prone. I might tip the head of the table about 30 degrees to distend the dural sac in the lumbar space. And again, usually they look like this at best, okay? Most of these patients, they're kind of fat, they're sick, they're old, they can barely, cooperate with the procedures. This is like some young patient in a journal article. In real life, they're not this easy to do. Okay, so the first thing I do is I will tip the image intensifier. Now, a little bit caudal oblique relative to the spinal canal because I'm trying to open this thing up. It's like a keyhole. And what I'm trying to do, this is called the Scotty dog right here, okay? The pedicle is like the eye of the Scotty dog, okay? Transverse process is the nose of the Scotty dog. The inferior facet's the ear of the Scotty dog. And then the inferior facet is the leg of the front leg of the Scotty dog. Spinous process is like the back leg of the Scotty dog. And right here where the Scotty dog would take a piss, that's where the interlaminar space is, the little keyhole. And this is the money. This is what you're trying to obtain. Okay, so once you can show this little keyhole space on fluoroscopy, and it's typically going to mean tipping the image intensifier caudally relative to the patient, and then tipping it towards you, ipsilateral, towards you. And then you're going to line up the needle here. So here is the hub, and here's the tip. So in a perfect positioning, you'd have the hub directly superimposed over the tip. That's the only way you know exactly where you're going if the hub is over the tip, because then you're in a straight line. And this is what I meant by if I had this picture on the image intensifier. First of all, I would make sure that the needle is in the center of the field of view, so you minimize any parallax. Your positioning is much more precise when you're centered. The next thing is you can see it's high in the interlaminar space right here, okay? So what I would do is, in this case, I would put the hub hatch cephalad, because that's going to direct the needle in the opposite direction, caudal, so I can avoid bumping into the bone right here, okay, the upper bony ridge border of the interlaminar notch. So that's how I would do it, okay. All right, now sometimes you can't tell how deep you are. Normally you're going to feel two pops. You're going to feel a little pop when you go through the ligamentum flavum in the back. It's a big ligament in the back. Flavum means yellow. It's a yellow ligament, so to speak, anatomically. And then you might feel another pop right when you go through the dura. And then, you get a loss of resistance. So you go resistance, lamina, ligamentum flavum. Then you get loss of resistance posterior epidural space. Then you get more resistance in the dural. And you get a loss of resistance when you go in the CSF of the intrathecal space. But you don't always feel two pops. Sometimes you just feel one pop. You try to feel two pops, but you might just feel one pop. It's not always easy to tell. A lot of these patients had previous surgery, scar tissue. They're really fat. The needle's way deep in there, okay? Usually you want to go, somewhere around L2, 3, 3, 4, 4, 5. 2, 3 is nice because it's the shortest distance. I always check a pre-procedure CT or MRI if it's available. I want to know where the conus is. Conus is usually much higher. Usually the conus is around L1 or something, but you want to make sure it's not low. Usually you don't want to go 5S1 because the patient, you ever seen some of these people, they got like women, they got a big butt that sticks out like the trunk of a car, and they'll have all this fat back here, so you would need an extra long needle. You want to use the shortest needle you can because the longer the needle, more likely it's going to bend and make the procedure difficult. Sometimes I will go L5S1, the lowermost level of the lumbar spine, because that'll be the only one with a big interlaminar notch to get through. All right, now I'm going to go into more detail about doing the procedure. Here would be an example of the needles in place in the intrathecal space at L3, 4, and the cerebrospinal fluid CSF is being collected into a test tube. Always make sure you talk to the referral service before the case. How much CSF do they need? Anywhere from about 12 to 24 cc's. If they're doing tests for cytology, the patient has a possible, central nervous system malignancy, then you're going to have to get a lot more CSF. If you're doing a lumbar tap test for normal pressure hydrocephalus to see if they respond to it before consideration for placement of a shunt, you're going to need a higher volume. So you got to talk to the referral service about that. The most common indications are rule out meningitis, neurosyphilis. Sometimes you do it for pseudotumor cerebri type questions. Is there increased intracranial pressure? Let's see, what are other things? We'll do it for intrathecal chemo. Had to do a bunch of those. If the contraindications, if they have a clotting abnormality, like their platelets are below 50,000, INR, international normalized ratios above 1.5. If there's infection of the skin over the puncture site. If the patient's really uncooperative, you might need general anesthesia. Pre-procedure check. Like I said, you always want to see a pre-procedure CT or MRI. Make sure you know from the referral service, do they need an opening pressure or not? You'll want the patient prone for that or on the decubitus. Make sure you got long and short needles before the get-go. You can't always tell. Most patients you get with a short needle, 3.5, but have the long ones available because you might need them and you don't want to be running around looking for them in the middle of the case. Like I said, I like to elevate the head of the bed of the patient so that'll fill up the dural sac, make it easier to get into it. I showed you how to line up for getting in, knowing how to always start with the hub hatch towards you so you can see it and you can just adjust as necessary as you're working your way in. I'll also sometimes reposition the image intensifier. If I think I'm probably in but the needle doesn't look perfect with the initial view, I'll just reset and reposition hub over tip with the II image intensifier, and just to check, am I still lining up with the interlaminar notch, because a lot of times I am, and then I just go. I usually go in short increments at first because I'm feeling it out to make sure everything is right. But once I know if I got a wide open path to that interlaminar notch and my needle's hub over tip, I just go real fast and get in. Give most of your local in the sub-Q. That's where most of the pain receptors are. You don't want to give local too much deep. You definitely don't want to give local within the spinal canal. That can mess up your procedure, make the patient hypotensive. And it's usually pretty easy to tell unless they've had previous surgery. And then when I'm coming out with the needle, I'll put the stylet back in because I don't want to risk the chance of a nerve root prolapsing into the needle tip, and that can cause pain at the puncture site. I'll also make sure I put the table back flat. That'll decrease the likelihood of a nerve root prolapsing into the needle. And again, like I said, the stylet going in. I have the needle turned sideways as I go in, sort of the bevel parallel to the vertical dural fibers, because that causes a smaller hole in the dura, leading to lower risk of a post-lumbar puncture headache. I usually tell them, nothing strenuous for 2 days. I usually keep them post-procedure about 2 hours. Make sure they have a driver. That's sort of my usual approach to doing a lumbar puncture. The whole thing's done with sterile field, prep and drape, mask and gown and all that. Anyways, that's how I do a lumbar puncture. I hope you found that helpful.